It's a great pleasure for me to introduce our honorable speaker, Professor Tipu Sultan, who is going to talk about infantile spasm, recent guidelines, and available options. Professor Tipu Sultan is a true master of his field. He is doing a wonderful job in the field of child neurology. His team and his students are serving the people throughout our country. Professor Tipu Sultan has done MBBS, FCPS, FRCPCH from London, Masters in Epilepsy from Leeds, UK, Pediatric Neurology Fellowship from the Glasgow, UK, and currently working as Head of the Department Speech Neurology, Children's Hospital, Lahore. It's a brief introduction of Professor Tipu Sultan. Now I will request Professor Tipu Sultan to please start his presentation. Sir, please.
Thank you, Akeel, for the nice introduction. Genix for organizing this symposium webinar, which is about management guidelines and the recent advancement in the infantile spasm and West syndrome and related disorders. I usually start my talk from this slide, which is the Department of Pediatric Neurology during one of the Epilepsy Day, which is used to be celebrated every month on second Monday. I'm sure many of the residents, pediatric neurology fellows, and the pediatricians are aware about the International Epilepsy Day, which is regarding the public awareness. And the picture was taken during one of the Epilepsy Day in the recent past. So quickly, I'll move to actually topic, which is infantile spasm, epilepsy syndromes, and the seizures. As you are already aware, ILA has developed new guidelines about the classification of epilepsy and epilepsy syndrome way back in 2017. The previous guideline was established in 1989. So almost after about a time lag of 25 years, this new guideline have been developed, approved, and now widely used globally. And the minute changes in this recent guideline is from partial seizures to focal seizures, generalized seizures, and a new terminology introduced, which is unknown onset. Because what we have observed, particularly in children, that in many instances, we are yet not clearly sure about the exact onset of seizures. So that's why this new terminology was introduced. Second intro was because of the wide spectrum of etiological factors, all these components of structural epilepsies, genetic epilepsies, infectious, metabolic, immune, and again unknown, because still, despite all the advancements, we are not very much clear about exact underlying etiology. Subsequently, from the seizure onset etiology, there are, of course, types of epilepsies, and ultimately, a combo of many comorbid conditions make epilepsy syndromes. And these combos are including not only the seizure, its onset, its type, its etiology, its comorbid condition, but also the EEG. So having all these, having this base, and epilepsy syndromes come into existence. ILA's task force says a characteristic cluster of clinical and EEG features, often supported by specific etiological finding, which may be structural, genetic, metabolic, immune, or infectious. Like I said in my previous slide, an epilepsy syndromes comes into existence or come into a mind. So a syndromic diagnosis in an individual with epilepsy carries a specific prognosis and treatment implications. And that's why we pediatricians or pediatric neurologists or physicians are very much nowadays into it, that for every child or for every patient with epilepsy, they should be pretty much clear about the exact etiology or epilepsy syndrome. I'll start from these brief video clips, and that's why I was wondering that I might not be able to transfer this presentation to any other system because of the technical glitches which one may face during the presentation, because these videos are generally not very much familiar with other systems. So for the residents, it's really important to familiarize with these abnormal movements, because until and unless you are crystal clear about identifying these movements, you might not be able to actually diagnose epilepsy syndrome or epilepsy infantile spasm or West syndrome and many other neonatal epilepsy syndrome right at the age of their presentation, because the delay in the diagnosis may lead to not only significant brain damage, but also a long-term impact on the child milestone and subsequent cognition as well. So I'm sure many of the residents and the pediatricians, they are looking into these videos and the subtle movements. It's really important to be crystal clear. So now from that initial slide, look at these subtle movements of infants. By definition, infant is a child beyond neonatal period, which is more than 28 days of life, under the age of toddler. So somewhere between 2 to 4 months up to a year are classical age group of infants and the classical age group of infantile spasm. So that's why these jerks are called infantile spasm. These sudden quick jerks are majority of times initially evaluated by a general practitioner are mistakenly labeled as either abdominal colic or anything related with the either abdomen, throat, ear, or nose blockage, etc. So that, as I said earlier, delay in diagnosis has significant devastated effect on the long-term cognition as well as milestone of the child. So by definition, infantile spasm and West syndrome are now more or less are synonymous terminologies. Traditionally, a triad of infantile spasm, a specific EEG pattern called hypsarrhythmia, and developmental delay or maybe the regression is called West syndrome. So I frequently changes these two terminology during my presentation for the ease of my audience, that you should not be confused between infantile spasm as well as West syndrome, because nowadays these are interchangeably terminologies. So it is one of the most common epilepsy syndrome in early childhood, in early infantile age group. So if we go back into the history, an English physician, William James West, it was the 17th century, who first described this in an article which was published in 1841 in the one of the most prestigious journal of medical literature, Lancet. And his own son, James Edwin West, who passed away in 1860, just at the age of 20 years, even at that era, was the first known child or known patient of this infantile spasm or maybe West syndrome. And that's why the syndrome has been, since that time, labeled as West syndrome. Definitely, it's an age-related disorder. Mostly it is in early infantile age, like I said, between few months up to a year time. There are many etiological factors, and we'll discuss in the coming slides. And syndrome is often caused by underlying organic brain dysfunction, and the etiology may be perinatal, postnatal, or prenatal. However, in countries like Pakistan, where there is significant acquired problem of hypoxic ischemic encephalopathy and a big chunk of, because of the consanguinity and intermarriages of genetic, metabolic, and malformations. So perhaps the largest, if we discuss about the etiological factors in Pakistan or other developing countries, so probably hypoxic ischemic encephalopathy, which is perinatal, and genetic factors, which may be further subdivided into not only classically genetic, but into metabolic or syndromic or maybe brain malformation, are the second largest group. despite advancement in the genetics and the radiological factors, still in many children, we are yet not sure about the etiological factors. The pathophysiology for the development of these infantile spasm is again not very much clear, but the possible hypothetical underlying etiological factors and the mechanism involved is the changes or dysregulation in the GABA transmitter process. So hyperproduction of corticotropin releasing hormone ultimately led to the development of these infantile spasm. And probably there are more than one factor involved. And these hypotheses are the fact that certain medications like steroids are used in the management of spasm. These are some of the common syndromes and common chromosomal abnormalities in children with the infantile spasm or maybe the West syndrome. On the left side of the slide, you can see some of the metabolic, common metabolic abnormalities which are contributing into the development of West syndrome. And on the top, you may be surprised to see up to 30% children with West syndrome or infantile spasm, they have tuberous sclerosis. So it's really important for the physicians or for the physicians to actually examine the child as a whole, because in the initial few months of life, the cutaneous manifestation of infantile for tuberous sclerosis might not be as visible as in relatively grown-up children. So once you see these cutaneous manifestation of tuberous sclerosis, you would be more comfortable not only to pick the child as a tuberous sclerosis complex, rather to manage the child as a whole. So this is EEG, classical EEG of children with infantile spasm, which is called hypsarrhythmia. This is a chaotic cluster of all the leads, burst of high voltage with at times suppressed portion and at times without suppression. So in case of without suppression, like in this particular EEG slide, it's classical hypsarrhythmia, and the combo of this hypsarrhythmia, as I mentioned you before, combo of this hypsarrhythmia, this infantile spasm is called West syndrome. In other children, this EEG may be suppressed in between, which is relatively modified hypsarrhythmia is even more dangerous in children of relatively grown-up age group. So again, you can have this child who has a relatively different sort of hypsarrhythmia, and the cause for this child is particular child is tuberous sclerosis complex, and you can easily guess the age of the child because he's able to sit is a relatively older child. He's between 6 to 8 months of age group, and you can easily spot the infantile spasm. In some children, the movements, the spasms are in cluster, and at times it's so dreadful that one might not be classically able to easily able to pick and spot. And in these children, the EEG is even more worse as compared to the one if you see the EEG of this child, which is classical hypsarrhythmia, and if in this child, which is even more worse because of the underlying mitochondrial disorder, and the precisely diagnosis is early myoclonic epilepsy. So generally, these children presented with sudden, rapid tonic contraction of trunk and limb musculature. This is the characteristic description of infantile, and these movements followed by a gradual relaxation in the next half to 2 seconds. So movements are actually very rapid. So just imagine the total spasm lasted in just 3 to 4 seconds. So you can easily divide first 50 to 60% time, which is about 2 seconds, is for a jerk, followed by half to 2 seconds in a relaxation phase. And the intensity of spasm vary from subtle head nodding to a powerful contraction of the whole body. And majority of children, like you see and listen in some of the previous video descriptions, followed by a cry. And generally these spasms, they repeat frequently in clusters and in hundreds each day. They are further subdivided, maybe for the ease of residents and for the junior doctors, into lightning attacks, into nodding attacks, or in the old literature, like they are described as salam seizures or jackknife attacks, because the relatively grown-up children, they may actually drop their head, and that's why they are labeled as salam seizures. So as I said, they are lightning attack. In case of lightning attack, they are severe myoclonic convulsions of the entire body and several parts of the body. And again, the duration is just few seconds. While in case of nodding attacks, convulsions of the throat and neck flexor muscles, during which the chin is fitfully jerked towards the chest or head drawn downwards. So like in the just last slides. And the salam seizures or jackknife attacks are relatively in grown-up children, and who are able to not only sit, but able to stand as well. And they behave like jerks, looks like a salam, like in some of the Eastern Asian Oceanian part of the world. If you look into the premise of these infantile spasm or West syndrome, it's not very uncommon problem in globally. The global incidence is 1 into 3,200 up to 3,500 live births. But if we look into in developing countries, or more precisely into Pakistan, I'm sure the data or the prevalence is pretty higher. And boys are generally more likely to affect than girls. The reason is not yet very clear. However, possible hormone association or with these infantile spasms, and they're rarely in the grown-up children. In older, relatively older classification groups, they are classified into symptomatic as well as into cryptogenic and idiopathic. I'll go into the next slide in the after describing and explaining this. But currently, they are just divided into symptomatic and cryptogenic or idiopathic. Symptomatic are, by definition, those groups of seizure in which there is a definite cause found. So any cause which affects the brain, which led to the brain damage, could be associated with infantile spasm. And in up to half of the patients, we are able to find exact underlying etiology. And this group of symptomatic is growing with every day. Reason being because of the advancement in genetic service, advancement in the high quality images, advancement in the metabolic ability. So even in developing countries, still we are able to find the exact cause in more than 50% children. Some of the common reasons, like I said, the genetic is further divided into malformations, into metabolic, into other dysplasias. So cortical dysplasia, lysencephaly, Akeel syndrome, these are all genetic reasons for infantile spasm or West syndrome. Cephalhematoma, hypoxic ischemic encephalopathy are maybe the acquired causes. And some of the other, like I said, tuberous sclerosis complex, Sturge-Weber, Paeds syndromes, these are again genetic causes. Hypoglycemia, if it because of some other reason, but it could be secondary to in all those children who are developed in infant in those mothers who are already diabetic or gestational diabetes. So cephalhematoma and hypoxic ischemic encephalopathy, periventricular malacia, all are acquired causes. representing symptomatic group of infantile spasm. Here I have again divided this slide into two. One is kleptogenic and other one is idiopathic. Idiopathic is classically where we are yet not sure about the underlying etiology. And traditionally, cryptogenic is again more or less the same. However, in the current literature, both these idiopathic group and cryptogenic group are merged as idiopathic, or in some of the books as cryptogenic. But generally, in this group, it is genetic. So genetic likely, which is called cryptogenic. In the clinical examination, as I said, neurocutaneous syndromes like tuberous sclerosis and many other syndromes are one of the commonest reasons for infantile spasm. Tuberous sclerosis is a relatively broader syndrome with multi-dimensional involvement of the brain, heart, kidney, lungs, and the skin. So at the time of birth and initial few weeks to months of the year, we are able to identify these skin manifestations. And that's why I was just mentioning in the initial slide, one should always examine the neonate or the infant whenever confronted a child with infantile spasm, because of the significant association of tuberous sclerosis with these children, maybe up to 30%. Another common association is Down syndrome. So West syndrome or infantile spasm may be associated up to 5% children with Down syndrome. And clinical importance of this is that it's really difficult and challenging to manage infantile spasm with Down syndrome. And EEG record is even more grave in children with Down syndrome. So in this slide, I was just like to explain my colleagues in KPA and other parts of the world. You should be crystal clear at the start of the treatment or during treatment to differentiate between a child who has drug-resistant epilepsy and just benign movements. If you look into these subtle movements, these are the movements which are in fact benign sleep myotonia. And in all those bigger hospitals where there's a neonatal service, these are perhaps one of the most common movement, I would say, because they are not seizures or maybe myoclonus, which are mistakenly labeled as seizure and being put on different anti-epileptic drugs. So you just look at the movement of this young girl. It is, you can say that classical type of head nodding. Just look at this. You can easily differentiate, and followed by a shrill cry. So now coming to the perhaps most important component of infantile spasm or the West syndrome is the management. Management of infantile spasm is really challenging, both for the pediatrician, pediatric neurologist, and for the families as well. But the catch point or point for the good management is the early recognition. If you spot, if you recognize the spasm or the seizure right in the start of the onset, in the initial few weeks of the onset, the prognosis and the long-term development of the brain would be excellent. Contrary to where there is a delay in the diagnosis and ultimately led to significant brain damage and long-term sequelae. So earlier the start of the correct treatment, better would be the prognosis and the outcome of the child. So based on what is known today, prognosis is solely based on the length of the time that hypsarrhythmia lasts. This is the statement taken in from one of the article about the management. Today, we have a significant number of options available globally and also in Pakistan. But the classical treatment for the management of infantile spasm is vigabatrin or ACTH. I'll describe all these one by one. Vigabatrin is the first choice for the management of infantile spasm in general and specifically for children with tuberous sclerosis complex. The drug has been described and came into existence about 2.5 decades back. However, Europe is probably more smarter than US, approved this drug way back in early 21st century. However, the FDA approval was granted in 2009, so about 13 years back. And in recently, this drug has been licensed in Pakistan and now available in shelf for about 2 years, about 2 years. Yes, exactly. It was probably launched in November 2020. So there was a lot of hue and cry about its potential side effect. Some of them are common, some of them are relatively more severe. So as in every other anti-epileptic drug, somnolence, dizziness, fatigue, or relatively common side effects like in all the anti-epileptic drugs. However, weight gain, which is generally attributed with valproate sodium, is generally not up to that extent. However, decreased gain is the actually real threat faced and observed in the initial few years of its launch in US, and that's why US physicians and US regulatory were a bit skeptical to begin with regarding its license. And after complete satisfaction about its potential side effect of visual field effect, then they gave permission in 2009. And since its launch and since its approval in US for the last 13-14 years, no significant visual field defect side effect was reported in the literature in journal. So we can say, though this visual field defect or loss of peripheral vision was observed in the phase 2 and phase 3 clinical trials, but post-marketing data was not supporting to that extent, and it was fairly safe to use this anti-epileptic drug for quite some time, at least for 6 months. However, in some of the pediatric neurology meeting, when I discussed this potential side effect of vigabatrin with some of my colleagues who are working in US, they were pretty much clear about its use even for years, and still there was no such side effect was observed. So we can say the potential threat to begin with, which was described in the initial results, was relatively high. However, post-marketing data was not supporting this side effect. So it's fairly safe. Mechanism of action for vigabatrin is a bit confusing, so I would not go into the detail. However, its proposed mechanism is irreversible inhibitor of gamma-aminobutyric acid, and it is really a drug of choice for tuberous sclerosis complex with the infantile spasm and infantile spasm in general, like in West syndrome and in children with Down syndrome as well. In post-launch experience in Pakistan, if I share my own experience, in the past 2 years, I used this drug for almost all children who were initially not well settled with the previous regimes, which are generally steroids, because ACTH is yet not approved or licensed drug in Pakistan. So previously we were prescribed either oral steroids or other options. But with the license of vigabatrin in Pakistan, now in majority of children, I prescribe vigabatrin as a drug of first choice. And so far, I never experienced this potential side effect, which was mentioned in the literature. The other option in the management of infantile spasm is ACTH. Of course, it is again a good drug for the seizure control. However, the side effect profile, though the visual field effect was not into the question, but weight gain, especially trunk, face, hypertension, significant metabolic abnormalities, including the glucose and the calcium and the changes in the bone metabolism, osteoporosis, irritability, and potential side effect of congestive heart failure is, one should always keep this in mind. However, one important other point is, yet it is not a licensed drug in Pakistan. If we further expand our horizon in the management of infantile spasm, there are still many other options, and these are pyridoxine, valproate, topiramate, levetiracetam, zonisamide. Zonisamide is yet not easily available in Pakistan. However, valproate, topiramate, and levi are easily available in Pakistan. One should always give a trial of pyridoxine, and Japanese are the one who described this first in their experience, that right at the start of the diagnosis, right at outset, one should always give a trial of high dose vitamin B6 pyridoxine. And if it is working, then probably pyridoxine alone would be sufficient to treat these children, because since we don't have the facility of genetics, otherwise the ideal would be to first exclude pyridoxine dependent seizure genetically and then put the child. I have at least 3 children in my practice who are only on vitamin B6, and one of them is in his late teens and still using pyridoxine and drug free, seizure free. And the other one is our early teens, and the third one is in the age group of preschool. The development is normal in all. 70% children as far as the seizure reduction is concerned, but it's not easy and it's not the modality of first choice. So once you are not able to control infantile spasm with either vigabatrin, pyridoxine, and other options, then one should always keep this modality of choice for many other metabolic disorders, not only infantile spasm, but also like non-ketotic hypoglycemia. Prognosis is really, as I mentioned in my initial slide, is challenging. So prognosis is always varies from patient to patient. It's not, one can say it's always the same in every child. It's solely based on underlying etiology, number one, followed by the point where we spot, where we diagnose, and how we treat. The earlier the diagnosis, earlier the introduction of anti-epileptic drugs, the better would be the outcome. So it varies from patient to patient. I would take a few more slides to address my colleagues all across Punjab or maybe the KPK regarding the education. What we have developed in our hospital, it's the guideline and the booklets for the advocacy for the parents, not only for infantile spasm, but also for the epilepsy in general. So it's really important to educate the parents about the disease itself. And one of the most important component in the education is the management of status at home. It's really important that parents should be crystal clear how to treat if a child develop a status epilepticus at home or if they are away from the home. So position of the child is really important. Look at this young girl while walking with the mom in a park, develop this status epilepticus, and mom nicely placed the girl on the grass in one of the side position. The available options are either diazepam suppository or intranasal or intramuscular midazolam. So benzodiazepines are the drug of choice for the management of status, either at home or hospital. But available option as far as Pakistan is concerned, we have diazepam dispensable product as well as intramuscular midazolam. As I developed, I have explained this service of ketogenic diet just few slides back. We have a specific keto clinic in our hospital, And all the children who are either drug-resistant epilepsy or infantile spasm and yet not controlled with either of the anti-epileptic, whether it's vagobatrin or otherwise, we treat them with ketogenic diet. It's commercially also available with the name of KetoCal, but it's too expensive. So that's why we generally used to treat with our with the collaboration of our own dietitian. In all those children who are still not very much into the control group, this CBD oil is a relatively recent modality, though yet not registered, but however available. I'll take 1 or 2 more minutes before I stop and invite any questions and answer from the audience. And few of the questions are placed in the chat box as well. Innovation. So what exactly innovation is? Practical implementation of the ideas that results into introduction of the new goods and services in the improvement of services or the goods. So in simple words, something new such as invention or practice of development or introduction of the new thing, new drug, new modality, new clinic. For my youngsters or for those who are listening, like development of this diazepam suppository, development of this vagobatrin in Pakistan, development of midazolam intranasal or buccal would be called innovation. So I think all those young brilliant minds who are listening should work on these lines of innovation. And we still have a lot of potential to incorporate innovation in our daily practice, in our institutes where we are exactly practicing. So what this innovation in our department, the service of genetics in child neurology. This is a picture taken almost 10 years back in 2013 when we first signed this child neurology and genetic MOU with the University of California. And this was about 7 years back with University College London Institute of Neurology for the genetic service. And here is the outcome. We have developed and provide service to many of the children with who have developed these significant, devastating neurological disorders. Look at this one of the clinic, and we generally do these neurogenetic clinic after every 2 to 3 months, and the next clinic would be in February 2023. Still, there are many future options who are coming in the coming years and maybe the decade. And these includes not only some of the pharmacotherapies, but also non-pharmacotherapies like gene therapy, neurostimulation, stem cell transplants, epilepsy surgery, and some of the anti-epileptic drugs. These are some of the infantile spasm publications from our department in JICNA or other journals. So I will summarize this infantile spasm presentation with these few words. It's quite common in countries like Pakistan. The commonest age group is between first year of life, and epileptic spasm as the clinical presentation, EEG shows always hypsarrhythmia or maybe the modified hypsarrhythmia. It's a polygenic multifactorial problem per se, and the treatment of choice is vagobatrin, steroids, and ACTH along with benzodiazepines and levi. Prognosis is variable from patient to patient, and this is the recently approved, inaugurated University of Child Health Sciences and the Children's Hospital. Thank you very much. I'm happy to take any question. I think there are few I can see in the chat box. The first question was by Professor Aisha Zafar, and the question was about ACTH availability and dose. पहले question का answer है कि ACTH is, as I mentioned you before, is not licensed drug in Pakistan, though available in different cities, but not easily and quite expensive, but not available. The dose of ACTH is, it varies from patient to patient, from center to center, but in our practice, we use 150 international units, 150 international units per square meter of body weight. So 30 kg, a 30 kg baby is 1 square meter. So 15 kg means around 0.65. So the dose is 150 international units per 1 square meter. The next question is dose of pyridoxine you prescribe and for how long? As I mentioned, pyridoxine is only helpful in all those children who are pyridoxine dependent seizures. In those cases, dose may be varied from 2 to 5. Tablet is of 10 mg, so it varies from 2 to 5 tablets a day, and it's generally at least for first 2 or 3 decades. First 2 or 3 decades, or roughly you can say, if not a lifelong. But only for those children who are pyridoxine dependent seizure. In rest, you may give them as part of vitamin supplementation, but not as I said, 2 to 5 tablets. As far as the next question is duration of vagabatrin, generally we use vagabatrin for 6 months. And as I mentioned, yet not a single child presented in our cohort, in our hospital, in our practice with any side effect. However, the seizure control is almost maybe 95%. Next question is role of ketogenic diet in infantile spasm. As I mentioned, keto is reserved for only those children where seizures are not controlled either with the vagabatrin and the other therapeutic options, which includes ACTH, oral steroid, valproate, and levetiracetam. Then it comes to the ketogenic diet. If it's only for if you are asking only for the infantile spasm and Best syndrome. However, there are a few more indications of ketogenic diet, which is drug-resistant epilepsies, apart from the infantile spasm and Best syndrome, and some of the metabolic conditions, like I mentioned, non-ketotic hyperglycemia. The next question is, what should be the dose of pyridoxine to be effective? As I already answered, in case of pyridoxine dependent deficiency seizure, 2 to 5 tablets, or otherwise, maybe you may start with 1 tablet, and if it would be effective, then you may increase up to 1 to 2 tablets. But if it is not effective, then probably the role of vitamin B6 is not for the seizure control, then it's only as a routine vitamin. So should we do metabolic screen like amino acid during organization in infantile? Yes. I think whenever, and we are living in a country where there is significant consanguinity. So in all these cases, when you encounter a child with the infantile spasm, in a child who has developmental delay and born to consanguineous parents, this metabolic screening, plasma amino acids and urine organic acid is an option, should have been done, because many of them are in fact treatable clinical conditions like pyridoxine dependent and biotin responsive multiple carboxylase deficiency. So I'll start having infantile in tapering of vagabatrin. ठीक है. एक और question है कि अगर tapering of vagabatrin पे spasm दोबारा शुरू हो गए हैं, very important and good question. डॉक्टर साहबा, अगर किसी भी एंटी एपिलेप्टिक की टेपरिंग पे सीजर दोबारा शुरू हो जाए तो आपको वो दोबारा रीस्टार्ट कर देने चाहिए, क्योंकि उसका मतलब ये है कि वो दवाई काम कर रही थी और आपको वो दोबारा से शुरू कर देना चाहिए. प्रोफेसर आयशा ने दोबारा वेरी हाई डोज ऑफ प्रेडिस्टोन इज रिक्वायर्ड, द चाइल्ड डजंट रिस्पॉन्ड. How long should we continue before stopping it as non-responder and trying other option? ओरल प्रेडिस्टोन की अगर हम बात करें तो जनरली इसकी हाई डोज हम फ्रॉम 2 to 4 mg से शुरू करते हैं और 4 to 6 वीक्स देने के बाद उसकी टेपरिंग शुरू कर देते हैं. जिस तरह कि मैंने शुरू में बताया कि इट वेरीज फ्रॉम पेशेंट टू पेशेंट डिपेंडिंग अपॉन द सेवेरिटी एंड द नंबर ऑफ जर्क्स एंड द सीजर. हाउएवर स्टैंडर्ड प्रोटोकॉल की अगर हम बात करें तो इट्स 4 to 6 वीक between 2 to 3 mg starting dose and then tapering in another 4 to 6 weeks. So it means total duration would be 2 to 3 months. Initial 4 to 6 weeks, 1 से 1.5 महीना full dose and उसके बाद gradually tapering. और जिस तरह अभी पीछे एक क्वेश्चन आया कि अगर टेपरिंग के दौरान फिर आ जाते हैं तो फिर आप इसको प्रोलॉन्ग करेंगे और टेपरिंग को स्लो करेंगे. लेकिन यहाँ पे एक क्वेश्चन है कि बाज बच्चे ऐसे होते हैं, इवन इन माय प्रैक्टिस, जिनको मैं फर्स्ट फॉलोअप 2 हफ्ते पे जब करता हूँ तो वो उनका इतना कुशिंग गॉइड फेस हो चुका होता है कि शायद उनके लिए ये इवन अगर सीजर कंट्रोल भी हो कि उसको 4 से 6 हफ्ते नहीं देने चाहिए, क्योंकि अदरवाइज वो उनको साइड इफेक्ट प्रोफाइल उसका बहुत हाई है. सो इन दैट केस स्टीरॉइड जो है वो 2 हफ्ते के बाद ही टेपर कर देने चाहिए. और अब अगर 2 हफ्ते के बाद टेपरिंग में आ जाता है, सीजर का रिकरेंस आ जाता है, तो फिर आपको अदर ऑप्शंस पे जाना पड़ेगा, क्योंकि एक तरफ अगर ओरल स्टीरॉइड का कुशिंगॉइड फेसेस का साइड इफेक्ट बहुत सिग्निफिकेंट है, तो मैं इसी अगली प्रेजेंटेशन में वो भी तस्वीर दिखाऊंगा. तो इसमें इस चीज को जरूर कंसिडर करना चाहिए. फिर प्रॉब्ली स्टीरॉइड की बजाय वेगाबैट्रिन को या अदर डोज को आपको चेक चाहिए. नेक्स्ट क्वेश्चन है जी, if fits are not controlled in 6 months, then what to do with patient? I mean maximum time allowed for वेगाबैट्रिन. जी, अगर 6 महीने तक भी वेगाबैट्रिन के साथ फिट्स कंट्रोल नहीं हो रहे तो देन आपके पास ऑप्शन 2 बचती हैं. नंबर 1 ओरल स्टीरॉइड, नंबर 2 ACTH, और फिर अगर इन दोनों के साथ भी आप नहीं कंट्रोल कर पाते तो फिर जो है कीटोजेनिक डाइट. If child is initially having infantile spasm and later on change her phenotype and EEG also change, then what will be the treatment option? Can infantile spasm associated with KCNQ2 mutation? Very good genetic question. Yes. Answer it. 2-3 question. If child initially have infantile spasm, later on change of her phenotype and EEG also change, then what will the treatment option? देखिए जिस तरह बच्चा बड़ा होता जाता है, देयर आर चिल्ड्रन, ये बाज दफा जो है इन्फेंटाइल स्पैज्म वाले वेस्ट सिंड्रोम वाले बच्चे बाद में अदर एपिलेप्सी सिंड्रोम्स हैं, जिस तरह के ड्रेविस सिंड्रोम है, व्हिच इज अगेन वन ऑफ द मोस्ट चैलेंजिंग एपिलेप्सी सिंड्रोम, उसमें कन्वर्ट हो जाते हैं बड़े होने के बाद. और KCNQ3 वाली भी बात बिल्कुल दुरुस्त है. तो उस सूरत में भी आपके पास ये जो ऑप्शन होगी, क्योंकि जो वेगाबैट्रिन है अपार्ट फ्रॉम दीज अदर ड्रग रेजिस्टेंट एपिलेप्सी के अंदर भी आप इस्तेमाल कर सकते हैं. वेगाबैट्रिन की डोज पूछी हुई है, लास्ट क्वेश्चन जो इसमें आ रहा है चैट बॉक्स में. वेगाबैट्रिन की डोज जो है वो है अप टू 150 मिलीग्राम पर केजी पर डे. मतलब है कि अगर एक बच्चा 10 किलो का है तो 10 किलो को आपने अप टू 150 अगर देते हैं तो वो 1500 mg बन जाएगी. शुरू आपने करनी है 25 से. 10 किलो के बच्चे को 25 से अगर आप शुरू करते हैं, बिटवीन 25 एंड 50, 25 से शुरू करते हैं तो ये डोज बनेगी 250 मिलीग्राम. 500 मिलीग्राम की टैबलेट होती है. तो बट आई डिड, मैं ये करता हूँ कि 1/4 गोली सुबह शाम. इसका मतलब क्या हुआ, आधी गोली एक दिन की, और आधी गोली का मतलब हो गया 250 मिलीग्राम. और 250 मिलीग्राम वुड बी फॉर अ 10 किलो बेबी इट वुड बी 25 मिलीग्राम. सो आपने पहले दिन जो है 1/4 सुबह शाम दी. अब ये पहला दिन, दूसरे दिन, तीसरे दिन का रिजीम कर सकते हैं डिपेंडिंग अपॉन द सेवेरिटी ऑफ एंड नंबर ऑफ सीजन. और अगर रिलेटिवली कम होते हैं तो फिर आप 3 दिन के बाद भी ये इंक्रीमेंट कर सकते हैं. सो स्टेप 1 1/4. अब हम एक 10 किलो के बच्चे की बात करें. 1/4 गोली सुबह शाम 3 दिन, 1/4 गोली सुबह दोपहर शाम 3 दिन, आधी गोली सुबह शाम 3 दिन, आधी गोली सुबह दोपहर शाम 3 दिन, और आधी गोली सुबह दोपहर शाम का मतलब क्या हुआ, 1.5 गोली. फिर 1 गोली सुबह शाम जारी रखें. 1 गोली सुबह शाम का मतलब हो गया 1 ग्राम. 500 mg की टैबलेट है, 1 ग्राम, और 1 ग्राम का मतलब होगा 10 किलो के बच्चे के लिए कि हम उसको 100 mg पे दे रहे हैं. तो 100 mg इज एग्जैक्टली इन बिटवीन, दरमियान में, यानी 50 से लेके 150 तक अगर आपने दवाई देनी है तो 100 का मतलब हुआ कि बिल्कुल दरमियान में आ रही है. तो अब इसके ऊपर डिपेंड करता है कि ये सीजर कंट्रोल कहाँ पे आता है. जहां पे सीजर कंट्रोल आ जाएगा वहां पे आप इसको उसको स्टॉप करके, फर्दर इंक्रीमेंट को स्टॉप करके तो रोक सकते हैं और उसको चेक कर सकते हैं कि अब हमने आगे कहाँ लेके जाना है.
बहुत बहुत शुक्रिया आपका, आपके टाइम का. बहुत ही इंफॉर्मेटिव सेशन था. ऑन बिहाफ ऑफ जेनेक्स मैं आपका शुक्रिया अदा करूंगा. थैंक्स लॉट फॉर योर टाइम सर.
थैंक यू अकील एंड द टीम।
थैंक यू सो मच सर।
यहाँ मेरे साथ बैठे हुए हैं तब से काशिफ साहब भी, उनका भी शुक्रिया।